Assalamu alaikum. It's again psychiatry wrong series, like mistakes series. Start with this. Okay, this patient with bipolar disorder, bipolar 1 disorder, he's stable on valproate. Currently is on progestin releasing IOD devices and would like to remove within few months because she hopes to to become pregnant, as she wants to become pregnant, and we know that valproate is a drug which causes neural tube defect, is a good drug for these bipolar, but it is not good for the pregnant lady. So as she wants to become pregnant, so we will switch this drug. We will take a drug which is far suitable for these ladies, that is lamotrigine. So treatment for bipolar disorder during pregnancy in acute manic condition, you can use haloperidol, you can use other atypical antipsychotic like risperidone and olanzapine, you can use other antipsychotic like risperidone and olanzapine. Okay, and in acute depression, as she is depressed, so we can use lamotrigine, quetiapine and atypical antipsychotics. So she history of two other hospitalization for MDD at age 14 and age 32. So he actually comes for the depression. He wants such a drug which actually helps to carry on her pregnancy along with no pregnancy problem and maintenance. Lamotrigine, atypical antipsychotic and lithium, contraindicated valproic acid and paroxetine, it causes cardiac defect. Okay, this 77-year-old man, he is a retired accountant. Um, uh, he tells that he kept forgetting to turn off stove and could have easily burned the house. Could have easily burned the house. He previously remained he previously maintained a rose garden but now feels it's not worth of the effort. So he's losing interest. The patient's doctor says that he was due for medication refill last week but still a few pills left. But he sometimes forget to take them. Okay, his Montreal cognitive assessment is quite normal. Uh, Not properly normal, but normal according to his age. So looks like not vascular dementia. Vascular dementia is in this stepwise decline. Vascular dementia is a stepwise decline, but it is not stepwise decline. But it is not a stepwise decline. He is actually sad. That's why. Okay, this patient. Okay, why it is oppositional defiant disorder? I need to um, how the mistake series is not due to just reading question and discussion. It is due to find out the clue why these mistakes happen and why these mistakes happens and how we can overcome those mistakes. That's why the mistakes series of that's why the mistakes series. Okay, this 15-year-old girl is brought to the office by her mother. Okay, so why it is oppositional defiant disorder? When principal said her said her phone would be confiscated. She started arguing and impulsively cursed at him, resulting in suspension from school. So, family history: maternal aunt has depression. On mental illness, patient is irritable, sarcastic, and frequently interrupting when her mother is speaking. Moodiness, behavioral concern over an year. So, when I ask her to do housework, she gets extremely annoyed and slams at the bedrooms or in my face. So he's just angry, not intermittent, just uh, it failing multiple classes, blames her grades on boring teachers, unfairly penalized handling. Okay, it is the pattern of defiance of rules and authority figures. This word is very important. So he is arguing over her authority, like he is arguing on his principle. So pattern of defense of rules and authority figures, irritable mood, and blaming failures on others, suggestive of oppositional defiant disorder. For a diagnosis of ODD, the oppositional behavior must be excessive compared to the normative and age appropriate behaviors and observed during interaction with individuals other than siblings. Okay, why it is not intermittent IED, intermittent explosive disorder? It is characterized by failure to control aggressive impulses, aggressive impulses and presence with recurrent physical and verbal outbursts. Okay, and for 40 and throwing things away, special magazines, newspaper. So her husband is concerned large pile in the patient attempted to clean rooms and throw things away many occasions, but always becomes severely anxious at the thought of parting with various items. So it's an obsessive compulsive disorder. Sorry, it's an hoarding disorder. Looks like obsessive compulsive disorder, but Uh, this patient has characteristic symptoms of hoarding disorder, a new disorder in DSM-5 that is distinctive from obsessive compulsive disorder. Hoarding disorder is characterized by accumulation of large number of possessions that may clutter living around the areas. And at any point, patient experience distress when attempting to discard possessions. Um, Patient experiences intense distress when attempting to discard possessions, and regardless of the actual value, CBT for target for hoarding behavior and SSRI can be considered as an adjunct. Okay, 13-year concentration difficulty. Hmm, her mind goes blank, unable to remember. She wanted to say, lack of attention. So looks like a generalized anxiety disorder. He is on excessive worry. He is on excessive worry. Like this 13-year-old girl comes to the office with her mother due to concentration difficulty. So he comes with a concentration difficulty. When called on by teacher in the class, her mind goes blank and she is often unable to remember what she wanted to say. Although she has maintained average grades, the patient is concerned her recent lack of attention will cause her to uh, fail out of school and not attend college. The mother says I have to constantly remind her to calm down and calm down and focus because she gets wound up so easily. She gets wound up so easily about everything and thinks the worst is going to happen. She has been like that since she was little. Vital signs are within normal limits and growth curves are tracking consistently. Physical examination, no abnormality. So he has GAD, generalized anxiety disorder in children, excessive uncontrollable worry on multiple issues, more than 6 months, and one or more than the following symptoms: restlessness, fatigue, concentration difficulty, irritability, muscle tension, sleep disturbance. Okay, next. Although you enjoy drinking, do you think that it maybe played a role in missing your daughter's game? So effective brief intervention for a school, effective brief intervention for alcohol abuse require an abstinence and require an understanding of the patient's level of awareness of the problem and readiness to change. When the patient does not acknowledge the problem, the physician's roles to increase the patient's awareness that alcohol use must be interfering with personal goals. Okay, this is bulimia nervosa because BMI is higher and it's not anorexia and restrictive food intake disorder. It's not avoidant restrictive food. So it's bulimia nervosa. BMI is normal. So although patients with bulimia nervosa often engage self-induced vomiting, often compensatory behavior like fasting, excessive exercise, although fasting, exercise. And this is the important for thing for or compensating the condition like compensate by fasting and running additional 5 miles the next day. Okay, this is decrease RAM sleep latency, sleep abnormality. In MDD there is decrease. In major depressive disorder there is decreased RAM sleep latency, low energy, this and that, and what about? Okay, sleep abnormality, a core symptom of depression. A characteristic polysomnographic finding of MDD is decreased RAM sleep latency. Polysomnographic finding of MDD is decreased RAM sleep latency. The time from sleep onset until the start of the first REM sleep period. The time from sleep onset until the first until the time from sleep onset until the first of the first REM sleep period, which is considered the biomarker of depression. Uh, other sleep findings Other sleep findings in depressed patients include decreased slow wave sleep, decreased slow wave sleep, increase RAM duration and density, increase RAM duration and density, as well as a disruption in sleep continuity. Sleep disturbance in MDD typically return to normal with antidepressant. Sleep disturbance in typically return to normal in antidepressant. Okay, the slightly increased risk of suicidal thought with antidepressant in these needs to be weighed against the risk of complete suicide in untreated patient. Okay, this is serotonin syndrome. How I have missed this. The patient is on dexamethasone and he has MDD. He has on fluoxetine. So he is on SSRI. He has taken these dexamethasone, and there is pupil dilated hyperreflexia and ankle clonus unnoted. Pupil dilated hyperreflexia and ankle clonus unnoted. Looks like serotonin syndrome. So serotonergic medication, especially in combination SSRI, SNRI, TCA tramadol, along with dexamethasone or amphetamine, along with dexamethasone or amphetamine or MDMA. Mental status changes, autonomic dysregulation, discontinuation of all serotonergic medication, supportive care, sedation with benzodiazepine, serotonin antagonist, serotonin antagonist like ciprofloxacin if supportive measures fail, immediate sedation, paralysis, and tracheal intubation if temperature is more than 41. If temperature is more than 41, so patient is on fluoxetine SSRI and concomitant use of another dexamethasone, another antitussive agent dexamethasone. So discontinuation of all serotonergic medication, management of severe hypertension, short-acting antihypertensive as mono, IV hydration, evaporative and convective cooling. Okay, and here ciprofloxacin should be used. Okay, venlafaxine. Why you are using venlafaxine to this patient? Extreme nervousness, irritability, muscle tension, insomnia, irritability, muscle tension, insomnia. The patient dreads. The patient dreads the possibility of being, uh, as a result, found himself unable to concentrate, perform his duties. He will be a good husband or father. Mm, so he's excessive worry about multiple things. So looks like generalized anxiety disorder. So in generalized anxiety disorder, you give SSRI or SNRI. The second line is benzodiazepine. So it is antisocial personality disorder. The patients after 18 antisocial personality disorder injuries identified, breaking the social norm, breaking the social norm. This is antisocial personality disorder more than 18. Okay, this one is delusional disorder, more than one delusion for more than 1 month. So patient believes that the newscaster is in love with her, combined with the absence of prominent psychotic symptom or significant mood disturbance. Looks like delusional or erotomanic disorder, typically higher functioning. Brief psychotic disorder. Brief psychotic is a disorganized, bizarre behavior, keeping lights off, closing eyes, covering ears, dishonest speech, nonsensical, and probable hallucination, whispering to himself in the dark, and following traumatic death of his father is consistent with brief psychotic. It's carried by psychotic symptom lasting for than 1 day, lasting between 1 day to 1 month. As is this, it is triggered by stressful event. Major depressive disorder, irritable mood, poor sleep, poor appetite, impaired concentration, and psychomotor agitation are consistent with MDD. This is obsessive compulsive disorder. So disturbing images she has been seen. I would like standing in the kitchen helping with mother chop vegetables. Terrible image stabbing in her back and with a knife would pop in my head. She describes counting down 5 out of 1 several times and mental status. She becomes tearful when discussing how she would never want to hurt her mother. She reports no depressed or mood